Hello and welcome to our review of the lupus literature from September. We record these podcasts for you every month, so you'll be able to keep up to date on the latest literature and expert opinions. I'm Chris Edwards, consultant rheumatologist at University Hospital Southampton and honorary chair of clinical rheumatology within the University of Southampton in the United Kingdom. And today I'm really pleased to be joined by Victoria Werth. Victoria is chief of the Division of Dermatology at the Philadelphia Veterans Administration Hospital in Pennsylvania in the USA. So welcome, Victoria. Thanks for joining.
Yes, it's great to be here, and I'm looking forward to this discussion.
Fantastic. Okay, so we've got a couple of things that we're going to talk about. So, every month we review the key publications, and this, of course, is for the month of September for the Lupus Forum. And there's a couple of things, and I'm going to kick off if that's all right. Let me just advance through the slides and we'll get into that. One more slide. There you go. So this is the first one we're going to talk about. And I'll advance onto the slide that starts to show data in a moment, but there's a few things I want to talk about. And I know you've been reading through it, and we were trying to understand exactly the dosing with this. So maybe we'll try and make sure we express exactly what we think is going on here. But the background to this is the importance of B cells in lupus is well established, and we know that from the fact that belimumab works in randomized trials. We also have lots of clinical experience using rituximab. And then various people, including Ed Vitale, the chair of Lupus Forum, Ed in his PhD was doing work that showed the people with lupus who did best had the deepest B cell depletion when they were treated with rituximab. So there's that story around B cell depletion, which is our theme perhaps for September with the other paper as well. So that's the first bit of background. The other bit is when you give rituximab to people with lupus, you often see after that B cell depletion an increase in BLyS, B lymphocyte stimulator. And so people got the idea that maybe we could combine these two modalities of treatment and we'd get better efficacy. We'd be depleting the B cells with the rituximab, and we'd be reducing the activity and the development of the B cells with the belimumab. And there are some trials, few trials that look at that. One of those is Mike Ehrenstein's trial from University College in London, which met its primary endpoint in a fairly small study of reducing anti-double-stranded DNA antibodies. So that's the second bit of information I think is important background. And then the last bit for me is about trial design, the desire to get rid of corticosteroids and how we make trials as good as possible as we go along. So with that, I hope that's the background which allows us just to advance. Right, so here's this paper. Aronow, first author, a number of famous clinicians on this particular publication that's in ARD. Efficacy and safety of sequential therapy with subcutaneous belimumab and one cycle of rituximab. It's phase 3. It's a randomized controlled trial. The patients all had pretty bad lupus. About a third of them had a SLEDAI over 12, about a third between 9 and 12, and about a third in that 6 to 8 range. They all had to be over 6. And then the patients were given belimumab, so all were given belimumab, and then they're randomized into 3 groups. And if you think I'm not getting this right, Victoria, do jump in and we can discuss it. But 3 groups all getting belimumab. First group get placebo rituximab as well as the belimumab. Second group get real rituximab, and that placebo rituximab and the real rituximab is given in weeks 4 and 6 after the belimumab have started. Those 2 groups also stop their immunosuppressants, their other immunosuppressants, by week 4, and then they start tapering down their corticosteroids to get to maximum of 5 milligrams per day. It could be less, it could stop if possible. And then there's a third arm, which is a kind of normal care arm in a way, which is they get belimumab, but they also carry on with their standard of care. So I don't know if you had any comments about that, Victoria. Do you think that's the right explanation for the way it's being given?
Yeah, no, I definitely do. And the timing seems perfect to me.
Yeah, okay. So then they go out to week 52 and then they're followed. Now, I think it's worth just reading briefly the objectives from the authors, because what they say they really wanted to achieve here is they say disease activity control in patients with SLE with corticosteroids and immunosuppressant withdrawal is a treatment goal. So being able to get away from using corticosteroids and reduce immunosuppressants. So they really big up the idea of this particular strategy as a way of reducing steroids. But I guess when we look at the results, there's a couple of things. There's thinking about the strategy, but is there any difference between belimumab on its own or belimumab with rituximab? So if we look across to the table on the right-hand side, you can see the percentage of individuals and the numbers achieving this primary endpoint. It's about disease control. It was quite strict. You had to have a SLEDAI score that was below a certain level. You had to be on that low corticosteroid dose. You had to be off your immunosuppressant. So I think the SLEDAI was 2 or less, wasn't it? So you had to achieve that. And for the belimumab and placebo, 16.7 achieved. For the belimumab plus rituximab, 19.4% of the patients achieved that. And then there's this sort of open label group for comparison as well. Now, that didn't meet its primary endpoint. The p-value is 0.53. And so at one level, you'd say, is there any difference between belimumab on its own plus rituximab? The authors also point out that you do get a percentage of people off their immunosuppressants and on low steroid. That would be the optimistic view. And also there are some other differences in some of the secondary endpoints around how much of the time people are doing well. And if you have rituximab and belimumab together, maybe not surprisingly, your double-stranded DNA antibodies are likely to be lower. And most of the B cell subsets that were looked at that were likely to be lower. So it's kind of in this stable of think about B cells, plus think about a combination of rituximab and belimumab, and then it's about strategy, because lupus trials have been so difficult to find endpoints with that. Victoria, did you have any thoughts about that? Anything else you thought popped into your mind when you read through that paper?
Yeah, not really. I mean, I think it's just very informative because, a lot of us thought that, with BAFF going up with Rituxan, that this would be a way of improving the outcomes. And we don't really see that here. And I think it really clarifies, the approaches that can be taken.
Yeah, absolutely. And I also wonder whether there are slight differences between the studies. Maybe they were making life really difficult for themselves, because in a way, what I wanted from this when I first looked at it is I wanted to know, is this another study, but a bigger study and a really well-organized study that looks at belimumab and rituximab being used together, but by also taking the steroids down really low and taking away the other immunosuppressants, they made it even more difficult for themselves to show that. I kind of wanted them to do that study before they did this study, but I don't know whether I'm being unfair with that.
Well, I mean, I kind of think it really helps highlight. I mean, one of the problems has been that steroids really cause such a huge placebo effect that, you can't see what's what. And so I think by virtue of getting rid of these other drugs, you have a better chance of seeing if there's a difference. I understand what you're saying, but I think this is probably the only way to try to, really get to showing a difference is if there is one.
Yeah, and maybe the steroids would have continued to confuse the situation and it needs to be removed. Yeah. The other thing I wondered about, I mean, in a way, the results around the double-stranded DNA antibodies and the B cell subset, that sort of stuff is similar to Mike Ehrenstein's Beat Lupus study. I did wonder whether there's anything about order. I think Beat Lupus had rituximab and then belimumab. This has got belimumab and then rituximab. I can't see why that would necessarily change things too much, but I guess potentially depleting first and then suppressing might be a slightly different strategy to suppressing and then depleting. I don't know. I'm not sure I know enough about the underlying mechanisms and pharmacokinetics to think that all out, but I wondered about the sequencing, whether that would change things.
I think it's entirely possible, right? I mean, because one of the thoughts, again, that Rituxan could be, increasing, BAFF, and then you come in with an anti-BAFF drug, and here you're not going to be able to show if that's what's happening or not. I mean, you're really getting rid of BAFF first and then coming in with Rituxan. So the order may matter, we don't know.
Yeah. And I suppose the last thing to say, I think the adverse events were pretty similar. I don't think there was a big difference. So that's useful information in terms of reassuring us that the combination didn't appear more dangerous. And slightly more people seem to discontinue on the belimumab placebo rather than belimumab plus rituximab, and that was both for physician reasons, physician decision, and patient initiated as well. If you look at the sort of flow chart of what happened, if we were trying to pick out optimistic signs in it. Okay, so interesting paper, another sort of B cell paper, and then we're going to move on. So I'm just going to advance the slide, and I'm going to pass it over to you, Victoria, if that's all right. So this is, thinking about B cells again, but the massively interesting area over the last year. Every month there's something new being published. Every meeting has a session on CAR T cell therapy. So what did you think?
Yeah, it's a fascinating paper. It is truly, this is really a hot area for lupus. There are many companies pursuing this kind of approach, and the technology is rapidly evolving. So I think it helps to understand where we're at in terms of why might this be different than, say, B-cell depletion with Rituxan. And so what this study did was to investigate B-cell depletion and secondary lymphatic organs of patients with autoimmune disease treated with CD19 CAR T cell therapy compared with Rituxan. And I think a lot of people have said, well, the depletion is greater, and therefore that's why the CAR Ts might work better and longer and get a remission. And so, but this is really a very specific way of targeting this to see if that's in fact true. And so they analyzed actually lymph nodes from 5 patients before and after getting CD19 CAR T cell therapy. And they wanted to look at the numbers of different types of B cells in the lymph node itself. And they also had inguinal lymph node biopsies from 5 rituximab patients who were also analyzed and using the same approaches of looking at various B cell subsets. And so I think what's really interesting is that, first off, there was rheumatologists that did these lymph node biopsies, and I don't know if people do that everywhere, but it sounded like it worked out pretty well for them. And so they also were able to look at non-lymphoid tissue from 3 additional CD19 CAR T cell treated patients. And they happened to have other diseases, and there was a kidney, and there were several other organs that were looked at. And they were able to also determine in the periphery if there were any circulating B cells, which there weren't for either the patients treated with the CAR Ts or with rituximab. And so the morphology was looked at by pathologists, and they did staining and special stains for the different antibodies that might be, or the different B cells that might be seen. And what they found was that CD19 CAR T cell therapy completely depleted B cells in secondary lymphoid organs and tissues of patients with autoimmune disease. And it also, interestingly, changed the follicular structure of lymph nodes compared with Rituxan therapy. So clearly, it was a somewhat different impact. And you can see here on the figure that if you look at pre-CAR and post-CAR, the peripheral cells go down similarly to what was seen with post-Rituxan. If you look at the peripheral immunoglobulins, they go down a little bit, but they're still considered to be in a normal range relative. And the same thing was true with post-Rituxan. And then if you look at peripheral IgM, that did go down in a number of patients post-CAR. And the significance of that is less clear, and that did not happen with post-Rituxan. So, I mean, I think that this is really starting to highlight that there are some major differences in the depth of depletion, and there are a number of reasons that were ventured forth as to why that might be. One of them was there antigen binding and effector functions that are integrated into one and the same cell in doing the CAR T cell, and therefore it's more impactful. Another would be that CD19 CAR T cells migrate to any tissue of the body and thus may be more impactful. And lastly, they have the potential to serially kill B cells because there's some persistence of these cells for a period of time. And so I think, this is a really interesting area. I think we still have to learn a lot about whether this is really going to result in a long-term remission, and what does the safety long-term look like. But it's a very exciting area, and I think this is really giving us some ideas of some of the differences in the outcomes for B cells after therapy. Did you have any other thoughts?
Yeah, well, I was trying to think about. So there's the first bit was, this is really interesting in terms of understanding the mechanism and the story around maybe the extraordinary efficacy you see in many patients, at least in the short, medium term, is because there's just much more B cell depletion and then the other effects on immunoglobulins. I was also thinking how that might help me clinically to know how well people respond, not just with CAR T therapy, but other varieties of immunotherapies, like some of the BiTE therapies that might come along, which may be more aggressive than rituximab, but not as aggressive as CAR T therapy, or not as potent, perhaps, rather than aggressive. You said there was a skin biopsy in there. Did that tell us anything about how many B? I was thinking, is there a tissue that's easier to get hold of than a lymph node that might give me a steer? Did you?
Yeah,
Were you able to see?
Yeah, I think it was in the person that ended up getting a kidney biopsy. They also had some skin and it did not show B cells. I will say, kind of just parenthetically, that there's been some work. We use a lot of rituximab for pemphigus, and we know the B cell periphery, the peripheral cells go down to 0 very quickly with rituximab. But there's some patients who have persistent disease, and there are different reasons for that, why that might be. But when someone has biopsied in a number of cases the skin of residual lesions and been able to find B cells in the skin after rituximab therapy, that, so clearly depleted peripherally, but not in the tissue. And so this could be a real issue in other organs as well, I think.
Yeah, I think that would be really interesting to know, because with rituximab, about half of my patients who have bad lupus skin just don't get better. It's a ballpark figure. And you think it would be lovely to have some steer, because from the blood test, I just have nothing that allows me to be certain why that's happened. Okay, so go ahead, please.
Yeah, what I would say about that, I mean, we actually have some patients with new onset cutaneous lupus in the setting of getting rituximab. And I feel like it may well be that we're knocking out even B regulatory cells early on. That could be important. And, so I think we still have a lot to learn about the biology of why it doesn't work as well in skin.
Yeah, okay. So maybe it's a sledgehammer that's taking out all the B cells, and we might, if we were selective, that might be an interesting approach.
Yeah.
Okay, well, those are the two papers. I don't know, Victoria, anything else to add before we wrap up?
Nope, I think we've covered those two papers pretty well.
Yeah, no, okay. So a little tour around B cells, B cell depletion, B cell control. So everybody, thanks very much. That's all we've got time for today. So thank you very much for joining me, Victoria. It's great to discuss the papers with you.
Enjoyed talking with you.
Great. And thanks everybody for listening. You can find the slide decks for these papers at lupusforum.com. The Lupus Forum is free to access and all the content is free to download. And don't forget to register for updates on the Lupus Forum. You'll receive email updates when new content's made available. You can also follow us at Lupus Forum, that's all in one word, on Twitter and LinkedIn. So thanks again, and see you next time.
Thank you.